Hi everybody, my name is Kim Prinsen and I am happy to be here with you today to talk a little bit about perioperative protocols and strategies to reduce OR complications. I work for 3M in the Medical Solutions Division and I'm a clinical application specialist. So I really support the antiseptic products that we use in our surgical suites and throughout the hospital, as well as other perioperative products. So it's a pleasure to be here with you today. I wanted just to start by talking a little bit about COVID-19. We know that there are a myriad of issues to consider in relationship to surgery during COVID-19, this COVID-19 pandemic. Unfortunately, there are a lot of resources that are available to turn to in terms of navigating how we're going to care for surgical patients and how do we care for our staff during this time period. So I just wanted to kind of set the stage and give you some different resources that you may be aware of or may not be aware of, but these are kind of good ones to go to and kind of look at questions that might have been asked that you have, answers for them, protocols that are in place, but really some good resources for you to have. So I think you can get a printout of this PowerPoint presentation and those will be available for you. So while we know that many locations right now are just performing surgery for emergency or urgent cases, we know that there are some locations that are starting to do elective procedures as well. And that rate really depends on what's occurring in that location. And each facility will have to determine what safety measures and policies and guidances will be followed to protect the patients and the staff themselves. But what I want to point out in this presentation is really the fundamentals of surgical care hold true during a pandemic as it does in any other time. So you'll still use those guidelines that are founded in research and evidence-based practice to reduce that risk of OR complications for the patient. Of course, will be, and not only OR complications, but transmission of disease as well. And the staff is without a doubt under kind of a heightened awareness of kind of the importance of aseptic practice, sterile technique, patient and staff safety. So with that in mind, we're going to talk a little bit about protocols that we might put in place for our surgical patients. So the objectives for our presentation today really is to discuss the aim of protocols in perioperative practice. What are we trying to do when we put protocols in place? We're going to identify 4 different strategies for implementation of a protocol, and we're going to examine a specific model that you can use to kind of put a protocol in place. We'll look at potential evidence-based practices that you can include in a protocol to reduce those OR complications. And then I'm going to take one of those steps in the protocol and walk it through the model so that you can kind of see what it looks like to kind of put a new process in place. And keep in mind, while this is specifically focused on the OR, these particular strategies and this model can be used in any practice area in the hospital. It can be used in sterile central processing. It can be used on the floor. It can be used in the ED. So it's a model that you can implement anywhere. The definition I like to reference is from the Institute of Healthcare Improvement. They use the term bundle. However, there are many terms that we could exchange here, such as pathway, protocol, care map. It doesn't really matter, but the important thing to understand is that a bundle is really a structured way of improving the process of care and patient outcomes. It's based on kind of a small, straightforward set of evidence-based practices. It's typically 3 to 5, and we know that when they're performed together and reliably or consistently, that they've been proven to improve patient outcomes. And using this bundled approach is something that's been done for well over 20 years, and it's been shown again and again to improve patient outcomes. We know that these particular bundles typically are based in evidence and research, and that the best approach typically is what's derived in terms of how to care for patients, how to deliver a specific therapy or technology that's used. And if you think about it, we see bundles in all sorts of things. Central line bundles are a very common one that we're familiar with. There's asthma protocols in terms of clinical practice. Sterilization protocols are certainly some things that are rigidly followed for best outcomes. So following that set of practice ensures a consistent result. So when we think about using a bundle, it's really a way that we standardize. And why is it important to standardize? We know that research shows us that if we have variability in a process, then we can have negative impacts from that in terms of prevention strategies and in terms of outcomes. And reversely, when we standardize care, when we use the same kind of set of rules or set of practices in the standard sense, then we see an increase in quality, there's a decrease in variation, and really a decrease in cost as well. So that's some important things to understand in terms of why we want to standardize care. And it's important, too, because we don't know, really, there's no way to predict who will get an infection or an OR complication. And that's because each patient has a unique immune system. They have different risk factors. Surgery is different for every patient, what we might find when we perform surgery. Bacteria have different levels of virulence or strength. And then we also know that there's a lot of concern around bacteria and their ability to form biofilms. And so for these reasons, what's important is to control what we can control through prevention and standardization. And that really reduces that overall risk of OR complications and ensures the best outcomes for every patient. So let's look at the protocol implementation strategies. So let's look at protocol implementation strategy. There are 4 different components. The first is to identify the bundle components, then we'll identify barriers, measure performance, and ensure patients receive interventions. And in terms of the bundle component itself, or the protocol component, what we're looking at is we're looking at what the data shows us. What are we finding to be a concern with our facility or with a specific service line or something that we've kind of found to be an issue that needs to be corrected. So we look at what that data tells us. We look at the evidence that supports how that can be improved. You know, do we validate that evidence? Is there research that supports it? And then we look at ways that we can standardize care or whatever that practice may be so that we can provide consistency in terms of what we're going to do for that care strategy or protocol. And I think the important thing to understand here is that in all of this work, when we're looking at identifying it, we need to look at it in terms of a team. This is not a one-man show. This is a group of people with various stakes in the game, so to speak, that will work together. So you should have somebody from the front line that's going to be actually performing the steps in the protocol. You should have leadership there to understand what can be done to support this team. And you need to have medical staff buy-in, specifically if it involves a surgical procedure or surgical protocol that's going to impact the patients that they bring to you for care. And so there's an infection preventionist. If it has to do with sterile processing, there may be people from various specialties that need to be on this team to kind of look at what that protocol is going to look like. And then what are those barriers? You know, are there barriers where you need to have administrative support? Is that going to be, is it going to be a problem to implement if you don't have it? So what are the barriers that might keep you from fully implementing a protocol? And then you need to agree as a team how you're going to measure performance. Is it going to be through specific surgical site infection rates? Is it going to be errors, or is your performance going to be the decrease in errors, or whatever that may be? That is something that's important to be agreed upon prior to implementation, so you know how you're going to measure success, right? And then how do you ensure that patients receive the intervention? And the way that you ensure that is by using a kind of a model to bring it forward, if you will. So that's what we're going to talk about next, is that specific model. So the model we're going to look at today is from Dr. Pronovost. It was developed in terms of being able to kind of translate evidence into practice, and it's a 6-step model. And the model itself helps ensure that patients receive the intervention that you're going to implement. So the steps involve engaging, educating, executing, evaluating, enduring, and then extending. And so we'll kind of go through each one of the steps here. So the first thing we need to do is really engage, and we need to help our team understand, why is this important? Why is this something that we're looking at? why is this protocol being put in place? Because if people understand the rationale for why we're doing it, you're going to have much better compliance around that. So we'll show kind of an example of what that might look like in a little while. But engaging and understanding why it's important and what stake is for them, what is their involvement going to be in that. The overall theme, obviously, is that we want to take the best possible care of patients that we can. And so certainly a story oftentimes helps illustrate why they want to be engaged in it. Some goals that are set forward will help people understand as well. So engaging is the first step in it. And then the next one is to show staff the evidence, and that in turn helps kind of educate people. So in terms of education, I think it's also important to understand when we educate, we certainly want people to be compliant with what the education is and follow through with it. There was an interesting article that I read that had to do with reasons why clinicians are not compliant with following protocols or evidence. And so I thought it was rather interesting. The largest reason, or the highest rated reason, was just lack of knowledge or familiarity with what it is you're trying to do. So I think that's important to understand, that people aren't always on the same page that we are, right? They don't always see the bigger picture or understand fully why we're doing things. So just lack of awareness is a big concern. Other things that are interesting too is really the attitude. Maybe they don't agree. There's a lack of agreement as to what the rationale is for that protocol. They may feel that they have a better way of doing things and they don't support that evidence. So it's really important to kind of understand where people are at when you're bringing things forward. And then part of it may be, they may have some ability or behavior concerns around a practice that you're implementing. Maybe they don't believe it is the best thing for the patient, or they think that they maybe don't have the skills to take that step to perform the protocol itself. So just having a good understanding of kind of where your staff at is important when you're educating. So when you educate, you really want to prioritize that this particular protocol is important and is a challenging task that we're all going to be working together to do. You want to inform people that the support is there for a protocol to be put in place in terms of leadership and medical staff or whomever your supporting team is. And then you want to really underestimate what your staff knows about the intervention. You never assume that everybody knows, and I think this is the time where you can overshare, and overshare in different ways. So maybe it's through a webinar, or maybe it's through some in-servicing that you're doing, but you want to keep that information in front of people, and you want to do it in several different formats because everybody learns in a different way. And then find creative and consistent messaging to communicate with your staff as well, kind of keep them informed in terms of what's going on. And that may be in terms of different things here while you're executing. So engage them, we have educated them, and now we want to execute this whole protocol. And what you do is you do different in-servicing. You conduct training on the protocol. If it's a product-specific implementation, then you may have vendors of that product come in and do the training. They may train trainers in your facility. So you want to make sure that you're in-servicing. You want to educate physicians and nurses together if that's appropriate in terms of the protocol. You want to make sure that when you're orientating new staff that you're including whatever your protocols are in that training, or if people are new to the unit or transferring to the unit as well. And then you want to make sure that there's evidence and information, literature available for people to utilize, because some people are great at hands-on training and in-servicing, but they also want that information to back it up and to be able to review it as needed. Then I think it's always important to keep staff informed as to what's going on. Display what the protocol is on some kind of an information board that you may have, what your goals are, facts about it, successes that you've had. Those are all really important things to have available for your staff as well. And then the final three steps really have to do with evaluating it. You remember that team should have based the evaluation on some measures that were agreed upon at the beginning to tell if your implementation has been successful. And then how do you make the plan enduring or sustainable? What's going to hardwire it? And this may have to do with repeated in-servicing on an annual basis. You may audit around it so that you can kind of make sure that you maintain and hardwire those practices so that patients have that continued outcome that you're wanting to see. And I think an important thing here is who else can this benefit? So if this is something that really worked well in your area in surgery, is it something that you can bring out to OB or the interventional radiology or the cath lab? So think about that as well. Where else can we move this protocol that it's going to be successful? So now we've talked kind of about what our implementation strategies are. We've looked at a model that we can use, and now we're going to talk more about specifically a different protocol that we can use in the perioperative area. So perioperative protocols can be around the patient themselves, specific to the patient. They can actually be protocols around clinical staff, things that processes you want to improve or protocols you want your staff to follow. And of course, they can be around environmental control. So sterilization assurance has a lot of different protocols that are in place in terms of how you decontam, how you sterilize, how you pack. You know, there's certain things that you follow all the time so that you have a consistent results. The particular one that we're going to talk about today really has to do with patient preparation and specifically the microbial load reduction. So let's step over to that. I think there's some good information that's important for us to understand as we're talking about microbial load reduction, and it really has to do with our human body, right? So this is our human body, and what we're going to talk about is the microbiome. And the microbiome really are the communities of microbial organisms that live in and on our body. And what we know is that there are approximately 100 trillion microbial cells on our body, bacteria, viruses, fungi, and there's about 37 trillion human cells. So at any one time, we're outnumbered 3 to 1. And the majority of time, that's not an issue. We live kind of harmoniously with one another. But where that can become an issue, and we can see negative impacts of that 3 to 1 ratio, really has to do with when we're bringing a patient to surgery, because at that time, we're making an incision to the patient's skin, which is their number one line of defense, and we're opening up the opportunity for microorganisms to move into the incision, and that can be a risk in terms of surgical site infection and OR complications. So it's good to kind of have some basic information around the human microbiome and understand that. Now, surgical site infections certainly are not things we want to occur, but what we know is it is the most common health-acquired infection, and they're associated with the most cost. The surgical site infection occurs in about 2 to 5% of patients undergoing inpatient surgery. And we know that with over 10 million patients undergoing surgical procedures as inpatients per year, that can account for 200 to 500,000 surgical site infections per year. Of course, right now we're in a completely different situation in terms of numbers of surgeries being performed, but we can expect that when we are able to, that those numbers will start to increase again. And I think the important thing, especially during this time, is when we bring a patient to surgery right now, we have an added concern of COVID-19. So we want to make sure that we are protecting our patients as best as possible because we don't want them to return to surgery. And so this is the time where we really need to understand the importance of following protocols. And in terms of microbial load reduction, that's one of the greatest things that we can impact. So research shows us that up to about 60% of all surgical site infections can be prevented with evidence-based practice. But that employs really many different things, the multifactorial approach. So it's not just one thing that we do, it's multiple things that we do, and that's kind of why we're going to be talking about this microbial load reduction protocol. So obviously our goal is really to reduce that number down to as close to 0 as we can. That really is our goal for each patient that comes to us for care. So the number one risk factor is contamination from the patient's own skin. And remember, that makes sense when we just talked about the number of microbial organisms versus the number of human cells. You know, we've got a large number of microbes on our skin. And we know that the skin can contain over 1 million bacteria per square centimeter, and it can take as few as 10 microbes per square centimeter to cause a surgical site infection. So I wanted to show you something here. This is 1 square centimeter on a fingertip. My colleague uses this as a great illustration to keep in mind that, you know, that's roughly a million microbial cells right there. And so it helps us understand how important it is to be mindful of reducing the microbial load on our patients when we're preparing them for surgery, and why we want to make sure we're doing everything possible in that arena. So by reducing the number of microorganisms, we can help reduce the risk of infection. It's pretty simple. Our goal is to kind of reduce it to the lowest number possible prior to making an incision in the patient's skin. So I think it's good to understand the surgical site risk equation. I think this is helpful for us as we kind of talk about microbial load reduction, but it's also helpful when we're talking to anybody caring for patients or doing work on things that may touch patients. So this is a great illustration. So the surgical site risk equation is really a conceptual formula that was put out by the CDC quite a while ago, and it holds true yet today, that if we take the dose of bacteria times the strength of the bacteria and we divide it by the resistance of the host, we'll have kind of an idea of what their risk of surgical site infection is. And so let's talk a little bit further about it. When we talk about the resistance of the host or the patient, we know that these are commonly known as patient variabilities, and some of them are controllable and some of them are non-controllable. For example, we can't control somebody's age, we can't control their nutritional status or what type of comorbidities they may have, but we can make sure that we prepare our patients for surgery and get them in the best possible health state that they can preoperatively. So for example, we may make sure if they're diabetic that we've controlled their blood sugar. If they need help with O2 saturation, then we might make sure that they're having some oxygen before they're going to sleep or as they're going to sleep. That's a pretty common practice, right? We want to make sure that they maintain normal thermia, or that their body stays in normal temperature throughout the procedure, because we know there's a lot of evidence that supports that normal thermia helps reduce multiple risks of the patient undergoing surgery. And decolonization, we can decolonize the patient prior to surgery. We'll talk a little bit more about that. So those are some of the things we can control and some of the things that we can't control about the patient or the host. Now, in terms of dose of bacteria, that's where we have a lot of control as a clinician. Of course, the hospital environment with OR ventilation, OR surfaces, traffic control, sterilization processes, those are areas where we really can focus on decreasing bacteria so that comes to the patient. Surgical preparation of the staff or clinical staff preparation, proper PEE used and then worn properly can make a big difference. Hand hygiene is one of the major things that we can do properly to reduce the bacterial load and reduce the risk of transmission of disease. What we're going to focus on really is around patient preparation, because this is where we really can reduce that microbial load on the patient prior to surgery. So it may be in terms of bathing, decontamination of the oral cavity, the nasal cavity, surgical skin preps, and draping, of course, are all some things that we can do to reduce that bacterial load. So I think that one of the things that helps is kind of to put some numbers to this risk formula. So if we assign everything a 4, this is obviously conceptual. The dose of the bacteria is the 4, the virulence is the 4, and the patient resistance to the host is the 4. 4 times 4 divided by 4 equals 4, right? But if we do something, take it one step further and we do something that can reduce that dose of bacteria, say we make sure that we've decolonized their nares, that we've made sure that we are using the surgical prep properly, that we have draped them properly, now we've reduced that risk or the dose of bacteria even further. So 2 times 4 equals 8. And we've kept the patient the same, divided by 4 equals 2. So we reduce that risk by reducing the dose of bacteria. And if we take it one step further and we look at the resistance of the host, so we do something to kind of bolster that host, we make sure they have a normal temperature throughout the whole procedure. We make sure their blood sugars are controlled. We've strengthened them, and so we've increased their resistance. And now 2 times 4, which is 8, divided by 6 equals 1.3. So we've reduced that risk even greater. So these are all things I think are good for people to understand, that we really can play a big role in the reduction of surgical site infection, and be mindful of the work that we do, and do it consistently and according to the standards so that patients have good results. So control what you can control. So specifically with microbial load reduction, we're going to talk about a protocol that you can put in place that is around preoperative bathing, nasal decolonization, surgical skin antisepsis, and creation of a sterile surface. Those are the things that we're going to talk about, because this kind of protocol, if you have each one of these steps in place, can really impact the patient, the result of that patient. So first we're going to talk about decolonization, and we're going to talk about both skin and nasal decolonization. So the CDC Core Strategy to reduce Staph aureus device and procedure related infections really has two steps. It's nasal decolonization and it's CHG wipes or wash prior to the procedure. And it's recommended for high-risk surgeries, which typically are cardiovascular, orthopedic, neurological surgeries or neurosurgeries. Those are the ones that are kind of considered high risk, but I would say that any procedure where you are having some issues in terms of higher infection rates or complications, those may be your high-risk surgeries as well in your facility. And so the strategy really focuses on making sure that these two steps are taken prior to the patient having surgery. So of course it makes sense. I think bathing makes sense, right? Talked about the patient's leading cause of surgical site infection is the patient's own, is from the patient's own skin. And so if we can decrease that bacteria prior to the patient coming to surgery, that's only going to be a positive thing for the patient. So we reduce that bacterial burden on the patient's skin. And there's evidence that supports that bathing with CHG is very effective at reducing skin flora that may not be achieved with just soap alone. Although the guidelines suggest bathing, they don't recommend one over the other aside from the CDC guidance that suggests that you use CHG cloths or wash prior to the procedure. In terms of decolonization, why would we be concerned about decolonizing the nose? Well, we know that, again, Staph aureus is a leading cause of surgical site infections. We know that 30% of the population carries Staph aureus in their nose alone. 30% are intermittent carriers and 30% are, roughly 30% are not. So we know that there's a risk of having Staph aureus present at the time of surgery. And we know that there's a direct correlation between Staph aureus present in your nares and surgical site infection. In fact, there was one particular study that was done that showed that 84% of the Staph aureus strains that were isolated from the nose were identical to those that were isolated from the surgical site. This particular study had done cultures of patients prior to surgery, so they knew what was in the patient's nose. And then after surgery, for those patients that ended up with a surgical site infection, they were able to kind of pair those isolates, and it indicated that the same strain of Staph aureus that was in their surgical site infection was identical to what was in their nose prior to surgery. So there's just strong evidence that by decolonizing the nose, we can reduce that risk of surgical site infection. So the CDC recommends two options for nasal decolonization. One is intranasal mupirocin, and the other is povidone iodine nasal antiseptics. Historically, we've seen a lot of use of mupirocin, but the concerns there really have to do with you need to know that in advance because the treatment is twice a day for 5 days prior to surgery. So there's screening that's done in this particular process. And then there's concerns around compliance in terms of following through. So sometimes it's difficult for patients to understand those directions twice a day for 5 days. And so, or they may be issues with just obtaining the ointment, the cost of it. So those are some things that are of concern. And of course, mupirocin is an antibiotic, and there are concerns with antibiotic resistance. Povidone iodine nasal antiseptic, there are brands that are specifically formulated to work in the nose. That's done the morning of surgery, so compliance is more assured, obviously, because you're either applying it to the patient's nose or you're watching them do it. And then because it's an antiseptic and broad spectrum, it has no antibiotic resistance, so there's no concerns with that. And there are positive outcomes that we know that when we combine nasal decolonization, when nasal decolonization is part of a surgical site infection reduction protocol, there is a reduction in surgical site infections. But those two things go hand in hand, the nasal decolonization and the bathing, preoperative bathing with CHG. Those typically are the two things that are together to help kind of have that SSI result. So the next thing we're going to talk about is surgical skin prep. There are things that we need to consider around this, and oftentimes people think, oh my gosh, I know everything there is to know about surgical skin prep, but I just want you to take a moment and we'll just talk through this because I think there's some interesting information that you'll discover. So obviously any skin prep that is on the market and marketed as a surgical skin prep has to meet the regulatory criteria for the microbial kill and persistent antimicrobial activity. So, you know, they're marketed and they've met some of the testing. And then most of the guidelines recommend that if possible, you should be using a dual agent or active prep that contains alcohol. So that's important too, because you'll have that immediate quick kill, and then the second active ingredient will have persistent activity. And then there are other factors that you have to consider when you're choosing a prep, and we'll talk a little bit about it, because there are different things that we need to consider, and that there is no one prep that's going to meet all of our prepping needs. If you have, for example, an open wound, you wouldn't want to put alcohol in, prep with alcohol in that area that you're prepping. So there's allergies and sensitivities that you're going to be considered when you're selecting a prep. So these are kind of specific to patient factors. You know, what's the skin condition? What's the age of the patient? So those are all things that you need to think about when you're selecting the prep for the patient. Certainly the surgeon typically has a preference of what he wants to use, and that's what we try to follow, but your staff needs to be aware of other things that they have to ask themselves when they're using a prep. What are the active ingredients? How do you apply them properly? The coverage area, if you're using an applicator type prep, make sure that you understand what the area is of coverage for that particular prep, because if you go outside of it, then you're not going to have the same efficacy that was intended for that patient. And then what's the ability of that prep to maintain antimicrobial effectiveness? You know, is it water soluble? Is it water insoluble? You know, will it stay on the skin throughout the procedure? Those are all things that you need to consider, especially if you have a procedure that's going to have lots of irrigation and that type of thing. So be mindful of that. And then one thing I wanted to talk about were prep and drape checkup data. We do audits where we go into facilities, our 3M clinical specialists, and they are kind of that second set of eyes that go in at the request of the facility to kind of observe prepping and draping practices and look for areas that you're doing well or areas that you may need improvement. And so it really is kind of a nice tool, and this actually may be impetus for possibly doing some type of a bundle, adding some information or practice to your protocol. So when we do these, we've done them all over the United States in various locations, various sizes of facilities in terms of large ORs and small ORs, ambulatory surgery centers, that type of thing. But this is information that we have found. The results show us that this is a total of 64 checkups that we've done. 31% of the checkups show that they did not select the appropriate prep solution. 69% did not follow the manufacturer's instructions for application time. 92% didn't follow the manufacturer's instructions for application method. And 78 didn't follow the IFU or the manufacturer's instructions for dry time. 91% didn't protect the patient and the linens when we're prepping, and then 16% didn't follow the aseptic practice when applying preps. So what this tells me is that there is still a lot of work to be done around prepping and helping staff understand specifically the variations between prep, and then how to properly apply it so that the patient gets the full benefit of that particular prep that you're using. So PrEP application affects safety and efficacy, right? So we want to protect the patient from pooling a solution, not only in terms of a fire risk if you're using an alcohol-based product, but also based on skin irritation that can happen to the patient when they are sitting in pooled solution. We also want to look at the instructions by the manufacturer, because how that PrEP is applied is how it was tested and how it got the level of efficacy that it had. So if you don't apply it according to the instructions, you may not be bringing the full benefit of the surgical PrEP to the patient. And remember, our goal is to reduce that microbial load. We started with the bathing and then decolonization of the nares, and we want to now step to the skin itself for reducing bacterial loads even further. And keep in mind that little kind of finger, that 1 centimeter, if you miss a spot, that leaves a lot of microbes behind, right? And then finally, we want to ensure that the PrEP is dry, obviously, again, to reduce that risk of fire, and also to make sure that we're not irritating the patient's skin in any way by leaving wet PrEP on the patient's skin as well. So let's take one step higher in terms of protecting that patient and reducing microbial load, and we're going to look at one other thing that we can do. So think about this. When we scrub our hands before surgery, we do that to remove the bacteria on our skin. And then we're scrubbed in for the procedure. Then we wear a gown and gloves to prevent the residual bacteria and regrowth from our hands getting into the incision and causing an infection, right? So that's the whole point of it. So if you think about that, you scrub the skin and then you protect it with the gloves so that you protect the patient. Is there something there that we can do that same kind of standard of care to the patient's skin? So understanding that the risk of contamination, we can't really sterilize the skin, right? We can prep it and we can get the bacterial loads down as low as possible, but there's always going to be some residual bacteria that survive on the skin surface, in the deeper skin layers, and in hair follicles. If we don't add kind of that added layer of protection onto the skin, there is potential for some of that bacteria that remains on the skin to be transferred into the patient's incision just through the normal activities of surgery alone, be it gloves, instrumentation, sponge, that type of thing. So that potential is there. So if we create a sterile surface on the patient's skin, then we can maybe add that next layer of protection. So the steps in creating a sterile surface really have to do with using an effective surgical PrEP to reduce as much bacteria as possible, placing those surgical drapes, sterile surgical drapes on the patient to create that sterile field. And then when appropriate, we can add that sterile Incise drape to create an actual sterile surface on the patient's skin. And that is a surface that can be created all the way to the edges of the wound when we make the incision. And that helps reduce that risk of transferring bacteria from the patient's own skin into the incision itself. So Incise drapes essentially are kind of a sterile plastic film. They're coated with adhesive, and it's placed over the area that you've prepped. You kind of draped out with your drapes, and you place that Incise drape over the area where you intend to make the incision. And the Incise drape immobilizes any bacteria on the skin and helps prevent items from surgery touching the skin and transferred into the incision. There are antimicrobial Incise drapes that contain iodine in the adhesive itself, and that helps keep residual bacteria under the drape at bay by killing anything that might still be there. It helps maintain that constant contact and helps continue to kill bacteria. So I think it's important to understand that guidelines around Incise drapes have evolved more recently. In 2018, the ARN finally supported the use of an antimicrobial drape if you're going to be using them, that they should be an antimicrobial one. And that's true for the other, some of the other organizations that have some guidance around, globally, that have guidance around the use of antimicrobial Incise drapes. Based on more recent evidence in terms of clinical studies that have been done, and I just want to share a couple of those with you. So this particular one is Reservoir and Associates, and this really looked at, it was a prospective randomized clinical study that looked at patients that were undergoing hip surgery, preservation surgery. What they wanted to understand was kind of the rate of contamination at the incision site. And so they looked at patients that had an antimicrobial Incise drape used versus ones that had no Incise drape used at all. And what they did was take cultures at specific points throughout the procedure. And they found that antimicrobial Incise Drape was significantly more effective at reducing microbial wound contamination at the incision site compared to not using one. At the surgery end, 12% of incisions with antimicrobial Incise Drapes were positive for bacteria, and those that had no Incise Drape had a rate of 27.4%. In fact, in this particular study, the study was terminated prior to the intended end date just because they felt like there was such a great risk to patients to continue on with these surgeries by not using an antimicrobial Incise Drape. So that kind of is a good illustration of why it's there and how it helps kind of control for contamination at the incision site. And then in this particular study, Bejko and associates, it really looked at comparing the efficacy of iodine-based Incise Drape versus a standard clear Incise Drape. And then this was a retrospective study of cardiac patients undergoing cardiac surgery. And there was a significant reduction, a 71% overall reduction in surgical site infections when Incise Drape was used versus when one was not used. And they also found when they kind of looked at all the costs associated with care related to surgical site infection, there was a cost of over $1,000 per patient when you used an Incise Drape with antimicrobial properties versus one without. So again, kind of support on making sure when possible that you use that extra layer of protection. All right, so we kind of talked about different strategies that you can use kind of in that protocol around reducing microbial load. We had 4 different steps versus kind of when we think back about what a protocol or bundle includes. And so when we do anything, when we introduce anything new, we also want to make sure we're not kind of throwing everything at everybody at one time. So we're going to do a new bundle. We're going to do 4 or 5 new things all at once. You want to take it step by step. And so there may be some things that you already have in place that you're doing well and you're just adding to it. So we'll look at how we might improve upon one step of this particular bundle and how we might use that model to do so. So first of all, we're going to talk about specifically around surgical preps because we have data that shows us from an audit that we are not, prepping practices are not in line with the guidelines and product instructions. So that we're gathering a team and we're going to talk about how we're going to do that. And our biggest concern, obviously, is that patient safety is at risk, right? If we're not following instructions for use and we're not prepping properly, then we're leaving the patient at risk. And that's something that we think as a team we can improve upon. So we're going to standardize what prepping agents that we are using, and we're going to allow for focused training for our staff, because if they have just a few agents to choose from, we can't go to one agent, obviously, because one's not going to meet the needs of every particular procedure. We're going to do training around those. We know that some of the barriers we're going to look at is just lack of training and or awareness of the issue. People just I don't think anyone comes to work thinking that they're going to do a bad job. They simply, if it's not being done correctly, there's some training concerns and there's just an awareness of the issue that needs to be brought to light. So we also know that when we have multiple choices, it can lead to confusion. So if we can kind of narrow that down, then we're going to have a better success. And then the other thing we have to understand is sometimes staff is really under pressure to complete things in a hurry. So we need to understand that we need to have some support from medical staff and from our leadership, that if we're going to do things properly, we need to be able to have the sufficient time to do it. So we've asked them to be on our team and help support that as well. So our baseline was the audit that was done. Our results showed us that we had some opportunities for improvement. We determined that we want to show some improvement in those percentages that we had, and we're going to do it by a return audit in a couple months after we've done our training, and then we're going to measure how well we're doing. So that's our strategy, and then we're going to use a model to implement it. So this is how it's going to look. We're going to engage our staff. We're going to talk about what our goal is, our goal is for patient safety, and we want to have no preventable surgical site infections. We want to make sure that we lower that number as close to 0 as possible. And we think that we can engage our staff if we do some education around the SSI Risk Equation and the role that we play in terms of staff, how we can impact that risk and reduce the risk. And the benefit of standardization is moving towards that goal of 0S surgical site infections. So that's how we're going to engage people, just to help educate them around, you know, what we can do as staff to help protect our patients. And that's really what our goal is. So why it's important. We're going to educate. We're going to talk about the importance of surgical preps, what the goal is for doing them, you know, why we do them. I think it's obvious. Remember, if we think everything's obvious, we may be missing some information that would be helpful for people. So we want to kind of overshare why we do it. We want to compare the antiseptics that we've chosen, maybe a little education around what they need to know and what kind of considerations that each patient, you know, in terms of allergies, age, what's appropriate, that sort of thing. So some education around the antiseptics themselves. And then for the ones we select for our facility, we want to make sure that our staff is truly understanding how the prep is applied for that particular product, and that how preps are applied really determine if they achieve the efficacy that they're supposed to achieve for our patients. So I mentioned already the surgical prep selection considerations, right? The person or patient themselves, and then the active ingredients, and then obviously the conditions that prep might be challenged under, and so how we might select for that. So we also have our vendors that we may bring in to execute training, or we may have them come and train some trainers so that we know that we're following the proper instructions for each product. We'll perform the preps using a specific agent according to manufacturer's instructions. We'll use the baseline consideration for prep selection. We'll talk about that in our training. We'll also talk about maybe some concerns that people have about proper prepping on specific surgical sites, because sometimes that's a concern too. You know, how do I prep circumferentially? How do I prep a patient that has a colostomy? How do I prep somebody that has dual procedures? Those types of things. So we'll do training around that, and then we'll assess for competency by utilizing our skills or competency checklists and document that. And so that seems fairly straightforward, and I think the important thing is that we train everybody. Even though somebody's been in surgery a long time, there may be things that they have forgotten, or they maybe didn't get in their orientation, or just helpful information to kind of understand the reasons or rationale behind what is being asked of us. It helps us be more compliant as well. So once we've done our training, we're going to have a period of time, and we, as I said, for our particular part of the protocol, we're going to go back and then we're going to assess for success. We're going to repeat the audit. We may look at surgical site infection rate. We may do a survey from staff satisfaction, pre-training to an evaluation time, to see if they feel like they're being allowed to have more time to complete the prepping process. Whatever that may be, we'll evaluate them, and we'll report that information for everybody to see. We'll report successes or things that may have happened that really worked well in terms of prepping patients. And I think one thing at this evaluation period, and probably up until this point, if there's something that comes up that makes sense to make a change, and you would want to make sure that that information, in terms of your protocol, that information is put into place and everybody's educated on it. So once you've evaluated it, how do you make sure that you sustain that result? How do you make sure that that protocol is followed? And so obviously annual training is something that you might do. Skills lab is something that you might do. You may continue to do auditing so that you understand when there's some variance from what your expectation are in terms of acceptable compliance. And so those are things that you don't want to just kind of one and done and just never look at it again, because when you take your eyes off it, that's when things tend to move back to a state that you don't want. So the other final thing is, if you're really successful in this endeavor, what other patients can benefit from it? Can patients in the cath lab, OB, interventional radiology, can they benefit from a similar training to help improve that patient care in that area? And my guess is yes, they can. There's ways to kind of extend that out to other areas so that we have great outcomes for all of our patients. So when you've kind of gotten one down and you need to implement another part of that protocol, another step. So the 4 steps were nasal decolonization, surgical skin prep, bathing, CHG bathing, and then, of course, sterile surface. You may tackle another part of that and do similar steps in terms of engaging the staff and making part of a strong microbial load reduction protocol. I think the important thing with anything that you choose to do is that you just have to begin somewhere. You need to look at what's working really well and where the greatest opportunity for improvement is, and then you kind of gather a team and begin that work. And I think that stakeholders in a team really help strengthen that team, as I said, so that you have many different voices to kind of bring things to light that one person may not think of, another one will, and so you can kind of have a better outcome when you have more voices at the table. We talked about a lot of the different things, and I want to make sure that we met our objectives. We discussed, the purpose of a protocol in perioperative practices. The overall is really to look at improving patient outcomes with a set of things put in place, be it practices, evidence-based practices put in place that have been shown to be effective at helping improve patient outcomes. We talked about the 4 strategies for implementing a protocol. We used a model to kind of walk through a protocol, and then we talked really about some specific to microbial load reduction, some potential evidence-based practices that could be included. So if you have any questions right now, I would be happy to answer them. I also have my email address there, so if there's any further information I can help you with, I'm always open to that, so please feel free to contact me. And with that, I will stop right here and we'll kind of open it up for any questions that you might have. Thank you.
Kim, thank you so much for providing that great information. We did have a couple of questions that came through, and I'm excited to have you address those. The first one is, what about decolonization of staff for those high-risk procedures? Can you address that question?
Sure, that's a really great question and a valid question. And how I would answer that is I'd tell you to consider what the intent of decolonization is, right? It's to reduce microbial load. And we have data that supports that to be effective within our patients. And so we can surmise that it could be true for anybody that uses it. And so what I would suggest is that you take that information, your infection prevention team, medical staff, whoever needs to make that decision at your facility, and just look at what evidence is out there regarding decolonization and kind of use that evidence to make some decisions on it. Certainly, it's just a really valid concern right now, especially considering the high-risk populations that we're going to be that we deal with every day, but also are going to continue to deal with going forward. So great question.
Thank you so much. And last question, could you just give a little bit additional information on how folks can stay up to date as surgeries do start to ramp up, especially in the midst of the COVID-19 pandemic?
Sure, Lindsay. I think the websites that I provided at the beginning of the presentation are ones that are they're fluid, so you can go back and go to those websites, and as we begin doing more and more surgeries and we have more and more findings, those will be updated with best practices, guidance that you should consider in your facility. So I would just encourage you to kind of keep abreast of those guidelines and those websites, and for any information, of course, that's put out by, of course, CDC as well. So that would be my suggestion, and I know we'll be learning more as we go forward here.
Wonderful. And for our audience today at the virtual conference, in your resources tool on your screen, you will be able to download the slide handout for this particular presentation. So you'll be able to access those resources that Kimberly presented on early on in the presentation. Also keep in mind that you'll be able to download a host of additional resources on behalf of 3M in that same resource tool. Take advantage of those. Kimberly, thank you so much for your presentation. We're certainly thankful that you're a part of the conference today. And everybody, we'll see you in a short while for the next presentation titled New Tools for Your Vaporized Hydrogen Peroxide Sterilization Toolbox. Thanks everybody for tuning in, and we'll be back soon.